All right, so I'm very excited to introduce our next speakers. We have Molly McDonald and Kimberly Strong from the Boulder County co-response teams. They are the social work clinical supervisors, and I'm going to turn it over to them to tell you all about the work they're doing.
Good morning, everyone, or almost afternoon, I guess. It's nice to meet you all. I'm Molly McDonald. I'm the program manager and one of the clinical supervisors over the Boulder County co-responder team.
And I'm Kimberly Strong. I'm the other clinical supervisor for our team.
But you'll learn why there's two of us very shortly. Shift, maybe? Nope. I'm not sure how to get to the next slide. Arrow up, arrow down. Okay, there we go. So just by giving a little context, this is our team and our team structure. We divide our team into an east side, west side model. So I supervise the co-responders that are on what we call the west side. So we serve the Boulder County Sheriff's Office and Louisville Police Department. Kimberly oversees the co-responders for our Erie Police Department, Lafayette Police Department, and then our full-time case manager as well. One thing that is unique about our team in comparison to other co-responder teams in the state and nationally is we do not require licensure of our clinicians. We really value experience and time in the field. We do not write the mental health hold, so we don't put our licensure number down when we're on a call that might require hospitalization. The officers do that. We provide language and some details around it, but that's one reason that we can get around not requiring masters and licensed clinicians. Some data about our team. Our team started in December of 2020, so really went what we call live in 2021. And some facts for you. In our first year, we responded to 737 calls. In 2023, we responded to 2,688 calls. So our team has grown exponentially from 3 co-responders and a program manager to here we are with 15 of us, and we also have a second-year MSW intern as well. So far, we're on track to get almost nearly 3,000 contacts with community members this year. Think of that one. So this is, again, just another picture of the areas that our team serves. In Boulder County. We partner with these agencies and really try and cater to them of what they need for hours of service. So we don't just across the board keep it 9 to 5, those sort of things. We are available 7 days a week except the major holidays. So I think it's 12 or 18 days we're not around. But for example, Erie, we started with 1 co-responder, we're up to 2. We're on our 3rd schedule with the Erie Police Department. We're really flexible in trying to figure out what works for each community and each jurisdiction to make sure that we're serving the people in the community that might be in crisis or need help. Who knows how many co-responder teams exist in Boulder County? Anyone? Yeah. No. There are actually, you were close. There are 4 teams in Boulder County. You have the City of Boulder, City of Longmont, CU has a co-responder embedded in their police department, and then our team as well. We also like to include Broomfield in our Boulder County collaboration meetings. So we meet monthly with those 4+ Broomfield teams to make sure we're up to date on what's going on in the world of co-response, staying active and talking about whether that might be employee retention or if we have dispatch numbers or radio or how are we tracked. So just making sure we're staying up to date with all that's moving in the field of co-response. We also do 2 in-service training days a year as a group of 5 co-responder teams. So one is coming up next week.
Okay, who in the audience are familiar with co-response teams and the Model N? Oh, that's impressive. I love that. We are still relatively new. As Molly mentioned, we started our team in 2020, so I love that people are aware of who we are. We are mental health professionals. We work alongside law enforcement for behavioral health, mental health crises, and we partner with law enforcement going on scene. Co-response is a relatively young field as a field itself. It started in Oregon in 1989 with a program called Cahoots, and from there it's really grown nationwide, and communities really tailor the model to meet their community needs. So it's going to look a little bit different even in Boulder County. It's going to look different at Erie Police Department versus of the community needs versus Lafayette, right? There are just different needs for our community members, and so we have the ability to tailor to that a bit. This is a picture of a co-responder going out with law enforcement. We received a referral from law enforcement about a gentleman that had his car stuck up in the woods, and a snowstorm was coming in. Law enforcement, they were not able to get the car out, so this is a co-responder with a backpack on, heading out with 2 deputies to give the gentleman some water and blankets to keep him alive through the snowstorm. And through that process, the co-responder was able to build rapport with him, and after the storm passed, got him connected to mental health services and medication management that he needed to have. So we offer a variety of services for our community members that you can see on the screen, such as crisis counseling, suicide prevention, conflict resolution, grief and loss support, substance abuse support, housing crisis, resource connection. We do a lot of resource connection and referrals for our community members, and then meet basic needs. And we require a minimum of 2 years of experience. As Molly had mentioned, we really value experience in the field, in some sort of field related to social work or criminal justice, so that we can have a really diverse team with a diverse skill set and knowledge to meet our community needs.
Yeah, one thing I would, typically people come to our team with about 5 years all the way up to 30 years of experience in social work or another profession. Kimberly and I have both been Boulder County employees for many years. We worked at child protection together for a long time, so there's a lot of diversity on our team. We had people that came from the Area Agency on Aging, so we really value people having some expertise in different fields and then bringing those and having cross-training amongst the team so that we can all improve our skills on scene, knowing we work with anyone across the entire lifespan, that we really want to make sure we're really well-rounded clinicians. So goals of co-response, right? At the goal of co-response programming, we are a diversion program. So we want to divert from hospitalization, incarceration, and law enforcement contact when it's related to mental health, behavioral health, and substance use specific, right? If someone's having frequent interactions with law enforcement because a neighbor's calling them in because of their unpredictable behavior or whatever that may be, we want to make sure we're connecting them with resources in the community that might be able to lessen that. Knowing we often, if someone is a criteria for hospitalization and needs to be held on an M1 or a 72-hour hold, we may not be able to prevent that one, but can we prevent the second or the third hospitalization from happening from there? That may look like supporting the family or friends or loved ones, or maybe even just doing direct work with that community member and partnering with other entities around the community to bridge those gaps and have some warm handoffs for the community members. Access to services, right? We have a full-time case manager. We also ask that co-responders manage some of the active calls that they go on. We do follow-up. We do offer a follow-up call on any active call that we go to. Our services are voluntary. So while someone may not be able to say, I can't talk to law enforcement, we do approach the community members with their own determination and autonomy of, you know, this is voluntary. You don't have to talk to me, but I'm here to support you if you need. And we find that that often really helps community members, like, break down a little bit, start building rapport with them, because we're not forcing you to engage in treatment. We do have familiar faces, people that we may come in contact with and are like, nope, not wanting treatment, not wanting services, but we'll be there for the next time when they might come up, and we'll always try. Even our case manager, we try 2 or 3 times to connect with a community member to make sure they have what they need. Efficiency of officer time. This is a little bit of the exception, not the rule for us, but co-responders can be left with a community member while law enforcement is not there. And sometimes community members prefer that, right? I was presenting at the Louisville Senior Center yesterday, and someone was saying, well, I called the police and it was 4 police cars and a fire truck and an ambulance showed up, and now I have all my neighbors questioning what's going on. I don't want all these marked cars and noise in front of my home. So there have been occasions, for myself, I was in child protection. I also was a drug and alcohol counselor for juveniles on probation in Denver. I have a really high threshold for working with beyond control of parent teens. That's not everyone on the team, but for me, if I'm going to a 911 call with an officer for beyond control of parent kiddo, and I'm feeling safe, there isn't any physical violence, the verbal has decreased, maybe there's no weapons, there's no unpredictability, I'm okay texting that officer saying, hey, it's okay if you leave, I'm okay by myself, and then I can really settle in with the family and maybe do an hour of acute counseling needs with them to de-escalate that, and maybe give them some skills and tools that might mitigate the next time that they need to call. I say that's the exception, not the rule. Most of the time, officers are like, I'm gonna go around the corner and do some paperwork in my car. I'm not gonna leave you here, and I wanna make sure that you're safe as well. So they keep our safety in mind. But a good example of, we can't go by ourselves. We really value the partnership between law enforcement and that co-responder to have that conversation and communication of if they feel safe on scene by themselves. We do a lot of cross-training. We cross-train with cities that we work with, but we also do it with officers as well. So we want to make sure that officers have some skill and some psychoeducation around what are some of these mental illnesses that are coming up and why are they seeing someone the way that they are for whatever reason. So we recently came in touch with someone who our working diagnosis is obsessive compulsive personality disorder. The co-responder was able to do a write-up of what does this diagnosis look like in practice or when we're on the street? What are co-responders doing to support this community member? And 3, what are some skills that officers can use when they come in touch with someone on scene so that they have some of those tools, that they're not just getting frustrated that this person isn't following their direction, right? What's some language that they can have in their toolbox to help them support the community member on scene. So we are overseen by the Behavioral Health Administration, formerly OBH. It's still in my brain. I still call it the OBH data spreadsheet, which sometimes drives Kimberly nuts. She calls it BHA. But this is how we categorize the calls that we respond to in our data system. So adult suicide, call might come in for someone, a friend or loved one, or even that person is expressing suicidal ideation in the moment. So we go out and we do an assessment. We partner with law enforcement. They use the Columbia Suicide Rating Scale to do their suicide assessments. So we partner with them in that. We also train co-responders to be able to do safety planning or support planning. I've been on scene with people where they may not be meeting criteria for a mental health hold, but they are clear that they need support and they need support now. So in one example, I was able to call a community member's family member and been like, can you come here right now? I was able to get 2 family members to the home. We wrote a safety plan together, was able to get the community member back on their medication, back in with their a therapist that day, and was able to get them back on eating and had a good night's sleep with the support of their family. On domestic dispute and domestic violence calls, we do respond with law enforcement to these. Again, we make law enforcement is trained really well on our safety as well. We are not trained law enforcement, we are trained clinicians. I have been, what I like to say, mom-armed a couple times where they're like, you can come up the stairs. So I walk up the stairs and I'm like, well, you can't come all the way up the stairs, it's not safe yet. I also am someone working with so many children, I sit on the floor a lot, which also makes law enforcement uncomfortable. They're like, are you sure you're gonna sit? I was like, I like the, lower the eye contact, power and control dynamics, those things. So again, we go back to safety a lot on our team. We actually have a training coming up this month, a 4-hour scene safety that is designed for clinicians by law enforcement of how can we improve our scene awareness to make sure they're not distracted by us being unsafe on scene. But that is a big one with the lethality or volatility that does come with some domestic dispute and domestic violences. Older adult populations, we are a community that has a large aging in place population, and so we work really closely with the Area Agency on Aging, Adult Protection. Right, yesterday we were at the Senior Center in Louisville, presenting to about 50 people at their lunch and learn that they do, and just letting them know what co-response is. That's usually the biggest thing. I think yesterday when we had asked, like, who knows what co-response is? There's like 1 or 2 hands out of 50 that popped up. So we just really want to make sure that people know that we're a resource and that we can be utilized in the community. Unhoused people, this comes up a lot in law enforcement. We have people that are camping or extended staying on private property, and so people call and ask that they get trespassed. And so law enforcement has to respond. And so how do we work with them? Maybe not to ticket them on the first time, right? Can we advocate? Can we give them 24 hours? Can we find a different place for them to go? We'll meet people at coffee shops, in the community, at our offices. Can we help them fill out any applications for housing or food stamps, whatever it may be? Like, we have a computer that connects to Wi-Fi. How can we be supportive in that moment? Parenting, I kind of talked about a little bit, but we do get a lot of the Safe to Tell reports, which are the anonymous reporting through school systems, where friends can report and say if something's going on. Child protection referrals, officers go out on, so we'll go with them as well. And then if there's just like a child issue that gets called in. So it's usually a parent that is like, I've tried everything, I don't know what else to do, and that's why they're calling. Substance use and addiction, I myself am a licensed addiction counselor, and this one we deal with a lot in Boulder County, right? There's a lot of co-occurring mental health and substance use that we're seeing on a regular basis. So how are we connecting community members with resources quickly? Being a benefit of being Boulder County employees, we have access to a lot of resources within the county. So Boulder County has a contract with some entities where typically, if I'm coming in contact with someone that is maybe expressing that they want to change their behavior around their substance use or misuse, I can usually get them connected to a therapist either on the phone to do an intake that day or the next day. But it's their readiness for change. So it's not always the case, but if they want to, we can connect them we work really closely with Tribe and Red Point are the agencies that we work with, and we can usually get someone on the phone rather quickly. It is a balance of honoring their self-determination and autonomy. We do go with officers to unattended death. That looks different. It might be a traffic fatality, maybe a loved one died peacefully in their home, whatever it may be. Co-responders are there. Our main role on the unattended death is to hold space for those that might be there, right? We attend to basic needs, make sure that they're comfortable, that they understand what's happening, because as you can imagine, those scenes are often chaotic. There's a lot of people there, right? Talk about a lot of cars and strangers in your home or in the area. So we really want to just mitigate the initial trauma response. If we're seeing someone in shock, right? How are we helping them ground, re-regulate, and get back into their body? There are 4 of us, myself included, that are part of the SWAT negotiation team. We are mental health consultants, so we are on call 24/7 with the negotiator team. So if a SWAT call comes in and negotiators are called out, a mental health consultant will go, and our role is to really give a mental behavioral health lens of what are we seeing behaviorally for this person. So if we're seeing a lot of paranoia, I was on a call where there was a lot of paranoia with a community member about aliens and bugs in the wall, and there was a decision to fly a drone in, right? So I was like, I raised my hand. That might just escalate a little bit, I'm not sure, but it likely will escalate this person, which they ultimately had to do to find the person in the home. But it did escalate, so at least officers were a little bit more prepared of like, this person has extreme paranoia, and we're sending a flying object through a window. That's great.
So the co-response, we have 3 models. We have primary response, secondary response, and then clinical case management. In the primary response model, this is when a co-responder is riding with law enforcement. We are in the car with them, we have vest on for safety, and we are responding to calls with them. So that could either be we start the shift riding in their car, or if we're at the police department and a call comes in and the officer's like, hey, co-responder, I'm gonna need some assistance on this call. So those are the 2 ways that we can be with law enforcement. When we get to the scene with law enforcement, we take their direction for safety purposes. Like Molly was saying, we are not law enforcement safety trained, so we take their direction. Is it okay to get out the car? And then how do we want to approach this community member? Would you like for me as a co-responder to take the lead, or wait for you to have some interaction and then introduce me? And we will also, for our main goal while we are on scene, is to stabilize the person in crisis. And that is what our role is as co-responders. For the secondary response, this is can be a couple of ways as well. We can be paged out. So law enforcement we have a 911 call, law enforcement goes to the scene, determines that a co-responder would be helpful. On scene, they will call dispatch, and then dispatch pages co-responders. They can either say, hey, come to this address and meet the law enforcement officer there, or they can say, hey, can you give the law enforcement a call? And if we are paged to the scene, co-responders call dispatch and say, hey, we're 10 minutes away, let the officer know. And we go on scene. And again, our role is to stabilize the person in crisis. We can also, I believe Molly mentioned this, but give some insight around M1 holds or language for the officer, because again, we are not the ones writing the M1 holds, the law enforcement officers are. And then Molly spoke a bit to the clinical case management, but we offer a follow-up after any interaction with a community member. Again, it is voluntary, but we will attempt to follow up with them, connect them to additional resources, or if we're on scene and it's pretty chaotic, we can say, here are some immediate resources, and leave a card with them, and then follow up when they are not so escalated afterwards. This is another aspect to our program, as just to be a community partner support. So we are in addition to de-escalating community members while on scene in partnership with law enforcement, we also go out and do trainings like this. And we have done trainings for community facing staff for the city of Louisville. We are not in Longmont. The city of Louisville, city of Lafayette, where we do like de-escalation training 101 with them. So if they have somebody who comes in and they're escalated and really upset that their water bill was out of control, we give them some basic skills so that they can de-escalate community members that could be disgruntled or upset. This is a picture of two of our co-responders giving training to the city of Lafayette staff. This is me. We have county provided vehicles, and so in our cars we carry a variety of supplies. We never know what kind of scene what need a community member is gonna be in, and so we can offer some basic supplies for that. We also have a small budget for client service funds. If somebody is in crisis because they don't have food or they don't have a coat, we have a small budget to help get them stabilized and out of that immediate crisis if that's something that they need. An example of this, a gentleman was discharged from a local hospital and he was walking around in his paper gown. Law enforcement somehow came into contact with him and asked for co-responders' help. We were able to get him clothes, some food for that immediate need, and get him on a bus to where he was wanting to go. Human dignity is a big piece of what we do, and we value humans and want to meet them where they are. So we have a small amount of funding to help people in those kind of circumstances.
Mental health and law enforcement. So, I mean, as clinicians, as mental health professionals, I think it is like, it's innate in us just to care and show up with, wholehearted and empathy with everyone that we come in touch with in the community, but that also means our officers, right? We are often faced with officers that are at minimums, they're having to work over, right? They're stressed, that resource is stretched thin. So how as we as clinicians, can we support their mental health in the workplace as well? In one of my 360 reviews a couple years ago, one of the officers wrote, "I know Molly's not my therapist, but she's really easy to talk to," which I thought was quite funny. So every May, Mental Health Awareness Month, we try and do a big push. A couple years ago, we did mental health bingo, where we made a bingo card and had a bunch of different activities for law enforcement to try and do throughout the day or when they were away from their office. And then we did a raffle of like a Yeti lunchbox and a hammock, things like that. And that was really funny. One of them was to hug a fellow officer. And if you took a picture of it, you got extra points. And so we have some pretty funny pictures of law enforcement hugging each other as well. This year we did a weekly reminder of like, what's a way that you can take care of yourself. And every week we came up with new flyers, and they were posted all around all of the jurisdictions, and we had little food and drinks and prizes at the end of every week for doing it. So this is one that we did around taking a mental or physical break. We do have someone on our team that used to be a graphic designer, so when it comes to these things, it's really nice that she can create some eye-catching pictures for us as well. We did something for Suicide Prevention Month. We made little baggies of lifesaver mints, made a little tie on it, and gave those to all of the officers as well, right? Really just trying to appreciate the work that they do. A lot of them are working 10, 12-hour shifts, so we really want to make sure that we appreciate them and know that we value the work that they do every day. Goals for the future, right? As we talked about, we've already seen exponential growth in the amount of employees we have on the team. So we're also looking at what does expansion of coverage look like. When we initially started, we were 12 to 8, 7 days a week. So now we are 6 a.m. to 10 p.m., at least Monday through Friday. There's a lot of people on the team with a lot of different schedules. I have to be very direct of what I'm looking at. And so right now we're in a process of collecting more data. Does it make sense for Boulder County to have a overnight shift? We don't know yet. It's something that we're trying to learn more about, get data collection around. I often, when officers ask for that overnight shift, I'm like, it's a great idea. And we're not an entry-level position program, and so finding a clinician, a seasoned clinician that is coming to us with some experience that wants to work the overnight shift, it's a little bit like finding a unicorn. Doesn't mean it doesn't exist and we can't find it, but it might be a little bit tricky to do. So we want to make sure that we're available when a crisis is going on. We're also currently looking at what does it look like as Boulder County employees to work on holidays. Is that something that the county will let us do, and what does a policy around that look like? So those are some conversations we're having. Integrating wellness programming into co-response, right? As mental health professionals and clinicians, we're not trained in the first responder world. So we're seeing and we're exposed to a lot of extremely traumatic events, and we want to know how that impacts the co-responder, especially how it impacts over time. So we do provide weekly clinical supervision for co-response. They get an hour, sometimes it's an hour and a half, with either Kimberly and I, and really processing through some of those tough things that they're seeing. But we also want to learn more of what else can we be doing, and how are we doing as a group, right? We're 15 people that are seeing very different things on different days, right? What's happening in NED is very different than what's going on in Superior. And we want to make sure as a team we're collectively healthy and that we can stay co-responders for a long time. We want to understand the unique needs of the communities that we're serving, right? Again, Nederland is a unique community in comparison to what we call as the Flats, Louisville, Lafayette communities. So how are we making sure that our co-responder up there is well-resourced and knowledgeable about what is impacting those community members, and how do we show up and support them in the best way possible? And we do that in each community that we're in. It is also reflected in the hours that we serve the specific community. We really want to be available and a resource to anyone in the community when we can. And exploring opportunities to collaborate with service navigation in the CAT team. We have a couple CAT team people over there. Hi. The mobile crisis team that's coming into Boulder County that started a couple months ago. We're working with partnering with them. What does that look like? How are we creating this crisis continuum of care in Boulder County, knowing that not all crises require a law enforcement contact? Can there be a different warm handoff going the other way? And if someone's in crisis that isn't having suicidal, homicidal ideation, maybe isn't violent, how can the CAT team members serve them, and as well with a well-mind navigation team. So really trying to just expand the crisis continuum in Boulder County, and what does it look like to respond to crises in the county, and then also statewide and nationally. We want to make sure we're staying up to date with what other programs are doing. We often get asked like, oh, are you guys like the STAR team in Denver? Because that's one that was really publicized a couple years ago. And we always say, a little different. We partner with law enforcement. STAR is a clinician and a paramedic. We are also looking into partnering with fire and EMS here in Boulder County. It's a little tricky with some HIPAA rules that we fall under in different silos and different nets. So we're working on that. Personally, I just gave 6 presentations to the Louisville Fire Department on co-response, some of our models, gave some mental health training as well, and how do we have a warm handoff and be collaborative on scene, right? We know that a lot of strangers, when there's a crisis going on, come up and inundate someone in crisis, and so how do we make sure that that's least disruptive and traumatic as possible for that community member? I think we have about 5 minutes left. Any questions? Oh, I see a couple.
First of all, thank you so much for your presentation and your work. I mean, it's absolutely had an impact in reducing unnecessary ER visits, and if it escalates, as you know, incarceration and arrests as well. My question is a little around dispatch. Mm-hmm. And so dispatch is really interesting, and I don't know if you have any data, but people can directly call the police department. They can call 911, and then there's 988.
Yes.
And so it's confusing to the public. Maybe it doesn't make any difference. Just make one of the calls so you can get somebody to help you. But do you get any data whether 988 calls are getting sent and that you're responding to those, or is 988 still in development?
Yeah, and I will say, one of the most escalated people I've ever been on, like I show up with 2 officers, we get a call for maybe someone with suicidal ideation, they had called the crisis line, and typically the crisis line you get about 20 minutes to talk. And so if something's not wrapped up, or if that crisis line worker is having some like, this doesn't feel great, I'm not sure, I need a welfare check, then we go. And that was maybe one of the most escalated people I had ever seen, because she had called the crisis line just wanting to talk to someone, ran out of time, and they called law enforcement and they didn't tell her. And so then we kind of had to do some repair work and like de-escalate things again. And so other than if a community member is telling us that they utilize the crisis line, then we don't have a way to track that data. What I will say is we give out postcards that have like a couple steps. If this is an emergency, call 911. If it's not, here's the non-emergent number. We also have the crisis line number and the text number on there as well for people. Crisis line or 988, yeah. Either or.
Hi, my name is Kelly. I do hospital addiction medicine. Thank you. I also want to echo that for the work you guys are doing in our community. I am wondering, although I know the answer to this question can be like a whole day seminar, but I hear you talk a lot about de-escalation. And I was wondering if there's like a specific phrase or reflection that you could share with us related to your de-escalation strategies.
Yeah. Great question. Now I'm like, gotta get back. I'm like, co-responder brain. If you're in crisis, you want to pretend? Just kidding. Yeah, I think a big thing for me is just one of the main things I do when I'm on scene. I think right now, right, I'm talking pretty loud, but we often call it your late night DJ voice. So it's low and slow. And if someone's yelling, right, that mirroring behavior to like co-regulate someone is typically like the basic 101 thing we do, right? And it's an interesting juxtaposition with co-responders and law enforcement, right? Because law enforcement's showing up, they got tasers, they got guns, they're in full uniform, we got lights and sirens, and then we're like in jeans and a little sweatshirt, and we want to be less intimidating looking, and that's why we choose the uniform that we have. But the biggest one, I think, is your tone and your body language when you're approaching someone in that initial contact. In our de-escalation training, we do a lot of like body-based interventions with like, if you can offer someone a warhead or sunny delight, right? Because even if you think of those two things, you think of like how that brings you back to your body and can re-regulate and center you. Another common one in our field is like holding ice cubes. Not things that are always easily accessible, right? When we're talking to like the front staff at the library, right? They don't have those things at their fingertips when someone's escalated up there. But those are, I would say, the late night DJ voice is kind of the how you approach with your body language and your tone. So there's a little bit of a nuance to it to make sure people don't think you're like talking down to them. I have not come across that, but being really low and slow and talking quietly so that you can have that co-regulation is usually my best trick for people.
I just want to echo, thank you for what you do. I think it's a marvelous service. Can you explain how you were different from victims advocates and how you coordinate, or if you do, or whatever?
Yeah, great question. Yes, we actually work really closely with victim advocates. Like I said, Kimberly and I both came from child protection for many years, and their current supervisor also came from child protection. So the three of us have a really great working relationship because we've known each other almost 10 years now. So that makes it really communicative and collaborative between us. So the difference, we are paid employees through Boulder County that we require experience and career history in the social work, psychology, criminal justice. Victim advocates, Boulder County victim advocates, they serve the Sheriff's Office, Louisville and Lafayette Police Departments, and Erie has their own within house. They are and Boulder has its own, and Longmont has its own. Victim advocates are volunteer positions. They respond to VRA crime, so Victim Rights Act, it's a federal act. When it is like a person's crime, so you think of like your theft, your assault, right? How did the crime impact me as a person, and I am the victim there. So there are often times where we are on scene. Unattended death is usually the highest one, that we are physically on scene together. So co-responders, right, that's where we hold space, we provide basic needs and basic resources for the community member, and we allow victim advocates, they have like pamphlets that have specific resources based on what happened there. If the family or community member is needing ongoing support, we partner together. Because victim advocates are volunteer, they may not be on another shift for a while. So that might be a scenario in which it gets referred to our case manager or that co-responder that was on scene of how do they continue to work with that family to make sure they feel supportive. But we love our victim advocates. We go to their monthly training once a month and work really well together.
Hi there. Yeah, I want to echo what everyone's saying. Really appreciate your time today. My name's Flannery. I'm a primary care behavioral health specialist with BCH. And I'd love if you could walk through what happens when a provider like myself calls in for a welfare check. And mostly knowing, can we request your services? Is that something that you all do and assess on your own in triage? Would just really love to hear more and get some clarity around that for our purposes.
Great. Yeah, so when a welfare check, if you call 911 or the non-emergent number for a welfare check, right, you're giving all of the information that you have. Co-responders on our phone and on our computer, we have all of the active 911 calls within the Boulder County 4 jurisdictions that we serve. So we ask that co-responders, that's one of the first things we ask that they do when they log in for the day. You're logging into First Watch and you're seeing what's going on in the county, and then we can read those notes. If we're riding primary with an officer, we're automatically going. You can always request a co-responder. That's a great practice, and then we really make sure that someone is there. So even there was a call recently in Louisville that came in at like 9 a.m. and the Louisville co-responder wasn't in, but the reporting party had asked for a co-responder, and the Erie co-responder heard it, so went. So we provide a lot of cross coverage that way. So then what would happen is we're reading the notes of what's going on for that welfare check, who you are and your relationship with that person, and we might be debriefing with the officer. While we're riding to that call, I might be, because I'm in the front seat, I'm not driving, I might be looking up in our system. Have we had contact with that person before? Does anyone on the team recognize that name, maybe from a previous job or position? And then when we get there, we're doing an assessment. So we usually do our first thing on scene is like mental status exam, right? Orientation to time, place, how is this person doing? We'll also rely on your information of what are you worried about, right? Because sometimes a welfare check comes in of like, I haven't heard from this person in a couple days. Sometimes they're really thorough of like, this person has expressed ideation X, Y, and Z, and I need someone to physically go. And so depending on what the content is, we might have to wait in the car until officers have deemed it safe enough for us. And then we can go in and do that assessment with them. So we use the Columbia Suicide Rating Scale to do assessment for suicidality in the moment. But we also are asking a lot of other questions, right? Because that's usually only like 4 or 8 questions depending on how they go. And we don't carry it in front of us. It's kind of, I ask them, all the co-responders, like day one, I'm like, take a picture of this and start to memorize these questions. You're gonna have to know them like the back of your hand. So that's a little bit of what happens like in the moment. And then it can take, depending on what's going on, we can take anywhere from like 30 minutes to 2 hours with that community member to decide. There is a lot of changing in policing around use of force in suicidal ideation if someone's a harm to themselves. And so we really come in as like the star of the show. We need to talk someone into going voluntarily to a hospital if they're refusing, because many jurisdictions statewide are not going to get into a use of force, meaning they're going to go hands-on, they're going to fight this person to get them to go to the hospital if it's a danger to self. It's different when it's a danger to others issue, but when it's a danger to self. So that's where co-responders shine, is being able to talk someone into, you know, I hear you're not on your meds, you can get in with a doctor and they can support you today. You can talk to someone at a hospital about X, Y, Z, right? And how are we supporting them getting the medical attention that they need. Does that answer your question? Okay.
Okay, so we have time for one more super duper quick question. Very quick, about a minute. What's that? Oh, it answered. Okay, perfect.
Great.
Anybody, one last question, thought, anything for our co-response? Okay.
A little bit of the, like, give us a tip and trick to walk out of here with. But what do you feel like is missing to better utilize or better resource you guys for our community?
Yeah. You know, there's a couple different ways that this could go. I think from a community perspective, people knowing that we exist. A lot of times people don't know that this resource is so inundated across police departments, right? We have probably the largest team at 15 in the state, with the city of Boulder's right behind us with 10 co-responders as well. So I think people knowing that this exists in the community is a great platform for us, because a lot of times people are like, when I'm on scene, they're like, who are you? what's a co-responder? I can't tell you how many times I've heard that over the last 3 or 4 years now. And so that's why neither of us are wearing them, but on the back of a lot of our t-shirts, it says co-responder in big, bold writing so that if a passerby was looking, they can see like, oh, that's a co-responder there. One of our next goals is safety. We recently purchased bulletproof vests for all of our co-responders that are gray, so we look different. Right now we're all in black. The hand-me-down ones from the sheriffs, so we got personalized vests for everyone. Right, like myself, I'm going on a lot of high-risk calls being on the SWAT team, and so we need to make sure that co-responder safety is at the forefront of it. And then kind of third from there is a lot of our programming is grant funded. Of the 15 positions, my position is the only one that's paid for through Boulder County. The rest is from, like Lafayette has a safety tax. If you buy anything over like $10 in Lafayette, some of that tax goes to our co-responder team. And so it is trying to figure out what is sustainable funding for co-response across the state and nationally so that it's not every couple years, every this, that I'm digging and I'm asking and I'm presenting at town boards. So sustainable funding is another one. And like Kimberly mentioned, it's a relatively new profession, right? Co-response in the state has really only been around about 20 years the way it looks today, right? There's been different iterations, but we really just getting more established as a profession and making sure people know we exist and that they can call us. Well, thank you all for your time.
Thank y'all.